Yes, welcome back. If you're just joining, this is Daybreak on Trust Television. And of course, we've had quite an interesting program so far. Well, we just wrapped up the Daybreak interactive session where Nigerians called into the program to share their thoughts, their perspectives on developments, especially around access to health insurance. And quite a number of Nigerians called into the program to share their thoughts. Major of the issue that they had was access to quality drugs, especially those that they couldn't afford at, the different health facilities that they went to. They complained about, being on health insurance and not able to access these drugs. Why are you on health insurance and then you go to the pharmacy to get drugs and you're told that, well, we don't have this drug in stock, you have to go outside to get them. You get outside and you realize how exorbitant these drugs are, which makes you to question the need for the health insurance in the first place. Well, we'll be continuing on that conversation this morning, but rather we'll be talking more broadly on the health sector and how it has fared somewhat. But then the Society for Family Health is a Pan-African non-governmental organization founded in 1983 and incorporated in 1985. It operates in 4 West African countries of Sierra Leone, Ghana, Liberia, and also Nigeria. Now, in Nigeria, SFH has 20 regional offices and 19 active projects are present across all 36 states in Nigeria, including the FCT Abuja, where the organization is headquartered. And this organization works in 6 thematic areas affecting family health in Nigeria, and these areas are implemented through different projects across several states in the country. And for this effort, the federal government has lauded the organization for its unwavering dedication during the commemoration of its 40th anniversary for improving the health and well-being of Nigerians, recognizing its transformative role in shaping the future of healthcare in the country. Now, with me in the studio is Dr. Omokhudu Idogho, the Managing Director of the Society for Family Health. Good morning, Doctor.
Thank you very much for having me. Good morning.
Welcome to the program. So, it's 40 years of doing this work in the health sector. Can you first of all tell us, about the mission and how this mission has helped to achieve the vision of the SFH?
Yeah, thanks. Our mission actually started from the lived experience of our founders. And it was an experience of a friend dying from a pregnancy-related complication. And that sort of whole experience saw Justice Ifeanyiwa Ezeako with our 2 co-travelers, that's pharmacist Dahiru Wali and Professor Likoiram Samkuti. Keep in mind, this was years before he became minister. Actually say, look, we must, as a people, do something. It belittles us for women to die from pregnancy-related cause, and that's really what led to our foundation. And the conversation was around how do you make change? How do you transform society? You could do it through governmental means, which it's really the sort of foundation, so to say. But you could also do it in terms of how the third sector, the NGO sector, can working as a bridge between communities on the one side, government on the other, the private sector. Sort of build a movement that really focuses on ensuring no woman dies from pregnancy-related cause. So that's really our journey, and that's a journey we've been on for 40 years. And of course, what has happened over the years is that as we work with communities, the needs of community change, and we have also had to evolve to respond to those needs in the years that had followed.
Well, in Nigeria, it says that you have 19 active projects. That's quite a lot. I can really not fathom, how much it takes to manage all of these projects across the country. But then, can you share with us some of what this project focuses on and, the impact that it has had over the course of the work that you've been doing here?
Our projects are what we like to call like the route to the business we do. However, overall, ultimately, the focus is always on communities. And so if you look at the work we do, even though you hear 16 projects, you can actually streamline them quite nicely into, for example, what I like to say, a bus that speaks to the reproductive, maternal, newborn, child health box. So that looks really at the almost life cycle, a typical family we have, from planning families to children, to the health of the children, to adolescent when they become adolescent. And within that space, we have programs, for example, that responds to malaria, nutrition, that's quality nutrition for children, project that speaks to safe motherhood, the ability for a woman during delivery to actually have skilled attendant, to be supported by community, so she actually presents in a facility and deliver in a safe space. We have programs that speaks to pneumonia in children, diarrhea diseases, the sort of what we call critical killers of children. So we respond to that within that bus. But we also have programs that speak very broadly to like health system. How do you strengthen health system? How do you improve health insurance? How do you improve the medicine commodity supply chain so that no matter how far, even as far as my village, in the far-flung of any part of this country, those medicines are there. They are good quality and they are affordable. So we work again across that as a whole spectrum of our work. We keep a very strong eye on gender. So looking at, of course, just to clarify, gender, men, women, there are different experience with the healthcare sector, which is very different. For example, you'll be shocked how much it takes men to actually be part of the healthcare system, both as consumer for themselves, but also in supporting their families to be part of that. And it was just International Men's Day, so again, that just speaks to that. Then we have programs that speaks, very broadly to, of course, a range of infectious diseases. So you're talking HIV, you're talking hepatitis, you're talking diseases around even some of the what we call health security related diseases, like during the COVID era and all that.
Exactly. I was just going to speak about volatile situations where you have, these outbreaks. For example, COVID. For example, you have a cholera outbreak. For example, we saw cases of Lassa fever and the likes. How has the organization been able to manage all of this in spite of its project that it's been implementing?
Thank you very much. I think that's a really exciting point. Like, we just had cholera outbreaks. And cholera, in many ways, a reflection of what we call determinants of health. They are not core health, but it just shows you that your water supply, your sanitation, the hygiene element around that whole process is not optimal. So the fact that we're having a cholera outbreak is exactly that. And our work in that space is very broad. It speaks to, we look at the idea of the quality of water we drink, the safety of that water we drink. So we have range of products, intervention that speaks from at the household level. For example, how do you treat your drinking water at the household level? How do you treat the water that comes from your tank? Because you see, interesting enough, you see a lot of middle class Nigeria, they are able to afford a water dispenser. However, when you want to eat your fruits, you're going to open the tap in your house and still use the normal water. So we've tried to intervene there by actually delivering a chlorine-based treatment that actually treats the whole water supply system from your tank in the house, water guard. So those are some of the interventions we do. So for example, during those outbreaks, we actually made massive community interventions. Of course, working with governments in those localities. We brought commodities, we worked with communities to look at the water supply. On sanitation, of course, the cycle, those two are not supposed to even talk together. And so the idea again is we do work that looks at sanitation, safety of sanitation, where it's done, how it's done, and ensure that there's never any link. And of course, the whole health promotion around that, talking to communities on what causes cholera, what needs to be done, that whole full spectrum. So that's how we intervene, even in other disease areas.
Yes, indeed. I quite understand, how it could be, especially when you consider that you need quite what I would call multi-layered or multifaceted strategy to deal with the different stakeholders across the value chain in the health sector, one of which is government, another, you mentioned quite a couple of times, communities. How have you been able, to sort of manage all of these factors put together? Because I understand sometimes some communities would decide to be laggards and not adopt any, of the strategies that you're trying to implement. How have you managed over the years, to circumvent all of this? Or do I say maneuver and manage? Let me not call it circumventing now, all of these processes.
I think the starting point for us is really what defines it. It's as a very proudly Nigerian organization. Our starting point is that there's so much social capital in communities. And therefore, how we approach the work we do is never to come and think we are the experts. We co-create solutions with communities. And our experience is being that when you come to communities, irrespective of what people think, that community may not be pro or progressive, in the way we define it. When you are able to have those conversations, interrogate the different layers, bring communities to some sort of like a round table. Across, of course, within communities, there are different power structures, and you bring them. Our experience has been, you literally succeed 100% of the time. Every community is defined by one thing. There's always an aspiration for better health. There's an aspiration for better life. But it's how you do it and the process you take. And that's really what defines us as an organization. Society for Family Health, over the last 40 years, foundationally we start from communities. We live in communities. We draw our strength and inspiration from communities. And that's really, for me, if you ask me, one of the many critical success factors, I would say that's been one of them. That's putting community at the very center of our healthcare. And I can tell you, even as an organization, some of the of what it means. If sometimes you sit with professionals, of course, we have very complex, very professional conversation that's talking to care at hospitals and all that. The average woman, the average man in community that has a headache, that has a fever, that has a diarrhea, is likely to go to a community pharmacy, is likely to go to a PPMV or what we call chemist shops. And we've worked in that space. We like to call them the pharma PAC system for more than 30 years. That's really at the heart of what we do. Trying to improve what those levels can provide. Trying to improve quality by investing in training. Working with government to look at tax shifting, tax sharing policy, because that's where community go.
I mean, when you do a needs assessment, for instance, you realize that the topography of Nigeria is really not equal based on the needs and the requirements of different parts of the country. Now, I believe as an indigenous organization that has grown over the span of 40 years, you've got presence across the different parts of the country, which means what might be required for communities in the south may be different from, what is required in the north. Now, talk about the north. We have issues such, as insurgency, banditry, and the likes of that. How have you been able to manage your communications and also the implementations of your project in spite of all of these different requirements that different communities need?
I think the desired outcomes for most health intervention, strangely enough, are almost the same, whether north, south, east, west. However, the approach to how you implement is what varies. And you have to customize that to the lived realities of communities you're working with. And that's something we've done for many years as an organization. We work in literally all the northern states. We understand the complexity around security. And so we've designed our programs over the years to be what we call community sensitive, to be conflict proof, literally. And it stems from a number of things. It's who are you working with? Who are the heart of what you're working with? So if you look at our programs, for example, in some of the core states in the north that are affected by banditry, you really must build it on local structures, local system, drawing strengths from the local institutions that are there. And more importantly, our messaging out there being that we are very much a organization committed to the health and well-being of communities. And so that has helped us. So you work with local people there, our staffing are from those localities. We ensure we understand the cultural, contextual needs of those places, the do's, the don'ts, and you try to ensure that all that is worked into your program design. All
right, well, Ghana, Sierra Leone, Liberia, Nigeria is where you have presence. I mean, over the course of the years, I know for some reason you might have had the need to do some sort of a comparative analysis, somewhat, of these different, countries that you now operate. What have been some, of what you've noticed in terms of the differences in implementing your project and what you have had to do, to adjust and readjust your strategies to fit the different locations that you now currently operate?
Thanks. I think one thing to even start with, one of the reasons that saw us go on this journey is actually how similar we are across the West African sub-region. Yeah, quite similar. And I could take it from different areas. So if you look, for example, you talked about the farmer value chain, or let me say the head value chain broadly. It's really interesting how across the whole West African sub-region, our head value chain is almost the same. Very similar, very limited investments. We're very dependent as a sub-region on importations, issues around the quality of medicines, which you talked about earlier, quality of infrastructure broadly. So pretty similar if you look at that. If you look at the patient experience or the client experience across, again, pretty similar, but with some differences, because this is the demand side of it. So For example, our experience in Ghana is that Ghana health insurance is slightly more matured in terms of coverage than Nigeria. And so it had meant that in working in Ghana, we've had to, in many ways, align our programs to strengthen that. You know what I'm saying? Because literally in Ghana now, you could say if 10 patients were to walk into a facility, theoretically, at least 6
a higher percentage
would be covered. Yes, somehow. So they don't have to pay out of pocket. Compared to our situation in Nigeria, where maybe 9 we have to pay out of pocket. So as you design programs in Nigeria, you have to keep a very, very strong focus on affordability, because most can afford. Families in Nigeria have to make decisions in terms of where they put resource. But at least that, to a reasonable extent, is different in Ghana. And so it means that you can actually look at your offerings, you can look at quality. Affordability will always be something, but not as a pressing issue. So that's looking at it from the sort of patient experience. From the sort of governmental regulatory part, I think relatively almost the same again. I would say Nigeria, in terms of it, maybe governmental regulation, a bit different. But of course, there are some sort of more fundamental difference, because we run a federal system. And so that means as you think health in Nigeria, you have to think the complexity of federal, state, local governments, and how that must all work together seamlessly to deliver for the patient. Compared to countries like Sierra Leone, Liberia, that are more sort of unitary, you know, for lack of a better word, that basically you have the central, then you have the districts, so to say. So, which is slightly a bit more compressed, and so therefore their processes are different. But overall, I think I would say, when I look across the West African sub-region, if I look at the direction of travel, all of us as a sub-region achieving the SDGs, I would say more similarity than differences. And really, that's why for us it was easy to scale to those countries with our offerings.
All right. Well, Dr. Idogho, there's this saying that success is success because it's the garment that shrouds all of the consistent failures. It's the uhuru, if you would call it that. Well, I would like to see your organization, or call it as a successful one, after existing for 40 years, 4 countries. So much has been said, so much has been done, but this means that it didn't come without some of its own challenges. I would like you to talk to us about some of them and how you managed to surmount them.
Oh, absolutely. The starting point, in my honest view, of every organization, should always, you would anticipate some challenges and bottlenecks, but the key element is, what does it mean for you? If it means that it's a lesson learning opportunity, then the way you approach it is very different. So absolutely, for us in SFH, once we set out to do our work, you've talked about differences in our community, the range of programs. It meant right at inception, sometimes we're already saying in our head, you know what, let's design this thing to actually know what works. So by the very implication of that, it means some will fail. It's a given. Some will fail. And that failing is excellent. And if you go through the literature, we are always happy to publish that. Though, in this community, we tried this method, it didn't necessarily deliver that. And that's great. It's great for what we call the body of science, the body of arts that are sort of connected to ensuring community health service. So that's what it's been. So when I look at the mission side, the work we do, we design them right from inception to say, let's figure out what works. I recall some years back, we actually did a quasi-experimental design. That's big English, but what it means is we actually say, okay, let's test intervention in a certain way. We do some here, we do a different one here, we see what works. And of course, some failed, and we then go back and say, oh, why did that fail? And that sort of process is going. But also at a more corporate level, there are also decisions you take. You say, let me do this, let me try this. Some succeed and really well. Some will not succeed so much. So that's the way I see it. And I think for me, our strength is really been the quality of colleagues, of teams we have, our people. Our board has been exceptional. Our board has been so strong. And so it's almost like, you could say, a DNA thing in the organization to learn. And sometimes in that process of learning, which is a major belief system, you will fail. And so the appetite to then say, oh, we made a mistake there, let's do it better, will, of course, take you to your next level.
Well, indeed. So I want to ask a final question, and that question is around how you would describe the appetite of Nigerian communities to health services. You know, we're talking about health insurance earlier. You mentioned there's a higher likelihood of seeing 6 out of 10 Ghanaians having insurance than seeing that here in Nigeria. Perhaps you could speak a little more, you know, about that and about how it's been trying to convince and to get more Nigerians, you know, to access health services for their own good.
I think there are two parts to that. I think you're absolutely right. I think there is the individual decisioning process to say, look, rather than me waiting for the unknown and then I have to look for that wad of money to pay, how do I actually make the investment to see that? And I think for us as Society for Family Health, that's an area we increasingly focusing on now to say, why are communities not making those decisions? And the lessons we've learned is it's quite a complex mix of reasons. From the ease for me to actually sign to insurance to a distrust of insurance. Would they even provide? It's one thing for me to be giving them this small amount every month, but when I need it, will they provide it? Can I trust them to provide it? Why don't I just put my trust on what I think works? So there's that distrust element you need to work on. To what is even the platform? Is it easy for me to make that contribution if I want to? So these are all on the sort of uptake side as community taking them. But also, of course, on the wider regulatory side, it's for us as an organization, SFH is quite pleased with what the government is doing. Some of the ongoing conversation, looking at regulating the whole health insurance industry, how it works, how it doesn't work. And then the third element often to sort of financing health is that health, no matter how you construct it, will always be, you will always require some sort of social interventionist mindset to healthcare, which means government also, and I'm sure you're very aware they have the Vulnerable Group Fund and all that. But the conversation is how much of that can we use to leverage our insurance industry and how much of it is like a standalone program. So that's all the sort of mix. But I honestly feel, and even as an organization, that we must move the needle now on how we finance health in Nigeria. Health isn't cheap. It just needs to be very deliberate. And our book we launched, we call it intentionality. We need to be intentional about how we actually craft an insurance scheme or a health sort of contributory scheme, because of course again it varies depending on what country.
Yes,
some are not comfortable with what insurance, some are more comfortable with what health contributory scheme. So we need to craft them, look at our context, but more importantly, look at how we pull them together to scale in the country.
Dr. Omokhudu Idogho, the Managing Director of the Society for Family Health, has been talking to us this morning on some of the work that they've been doing over the course of 40 years of operating, not just in Nigeria, but also different parts of Africa. Thank you so much for being a part of the program this morning.
Thank you. My pleasure.
Yes, indeed. And that's it for the discussion segment of Daybreak this morning. We'll be going on another break. And when we return, it will be time to look at stories that made it to the front page of some selected national dailies. Join us again.